For this to truly be a national vaccination effort, we must ensure equal access to the vaccine. National, state, tribal, local, and territorial practitioners and health workers from across the country working together can maximize access for all populations, especially those who are more likely to be exposed to or develop serious illnesses from COVID-19 and those who may face barriers to vaccination.
Me dolió un poquito, pero todo bien.
Have to be apart from one another is really hard.
It's all a part of Let's Do This, a campaign to educate and encourage.
There are more COVID-19 cases, hospitalizations, and deaths in areas where racial and ethnic minority groups live, learn, work, play, and worship. A comprehensive vaccine program provides equal access for all populations across the nation.
Welcome to Town Hall number 4. Thank you for being here today. My name is Dana Meany-Delman, and I'm a medical officer in the Centers at CDC's Vaccine Task Force. Like all of you, I have been focused on COVID-19 professionally and personally this past year. We have lost too many people to this terrible virus, over 500,000 people, and my heart goes out to each and every one affected by COVID-19. It gives me great hope that we now have multiple vaccines to fight this pandemic. While we have made incredible progress distributing and administering the vaccine in unprecedented and record time, there is still more work to do to ensure everyone in every community, everywhere, has access to and trust in the COVID-19 vaccines. As you may have heard in our plenary sessions, the COVID-19 program is built on 3 tenets: science, transparency, and equity. And for this national COVID-19 vaccine program to successfully vaccinate the US population requires a whole of community approach. The purpose and focus of this town hall today is to build bridges between public health at a federal, state, local level, and health systems across the country. So today we have an exciting session planned for you all. We are pleased that we have 5 esteemed colleagues and panelists from across the country from diverse organizations with unique perspectives. They will share their experiences on how they have worked to promote access and acceptance of vaccines across their communities. We are so grateful that these leaders, who are true vaccine champions, are here with us to share their work and their passion. By the end of the session today, we hope that you will each be equipped to do 5 things. The first is to empower community members and vaccinated persons to serve as vaccine champions. The second is to strengthen relationships with public health safety, public health systems, and others to ensure equitable access to life-saving vaccines. The third is to adopt some of the innovative strategies you will hear today. The fourth is to create new partnerships at all levels. And the fifth, and most important, is that as you hear about the different experiences and work that's been done around the country, that you tailor these approaches to your unique needs and the situations that you're experiencing. So let's get started. I would like to introduce Dr. Sue Visser, who will serve as my co-moderator. Take it away, Sue.
Thanks so much, Dana. So I'm Dr. Sue Visser, and I am the Associate Director for Policy and Extramural Program here at CDC's Division of Vector-Borne Diseases. But since March of 2020, I've been deployed to the COVID-19 emergency response here at CDC. And during that time, it's been my great privilege to serve in capacity of connecting our clinical partnerships to us as well as to each other, and to foster a sense of collegiality on this really, really important topic. It has been a great privilege and a great joy over the last couple months to get to know our panelists. And so I can't wait for you to meet them and to hear all of the ingenuity and innovation that they have brought about in their local communities, state efforts, as well as in their individual organizations. But before we do that, I'd like to know who you are. And so that we can customize our comments and our discussion for you, we're going to start with a poll that just asks really easily, who is in the audience today? And we'd like to find out what we have going in terms of the different groups that we've got here. So if you could just take a moment, we'll wait to collect that information. Great, and while that is tabulating, I will say what has been really lovely is Dr. Minnie Delman is a clinician herself. I am a public health practitioner completely. And so we represent a really nice bridge that I think lays out the topic for today's town hall. And as you hopefully are seeing right now in our poll results, we have a really, really diverse audience. We have about 10% of our folks from public health department. We've got some folks from the healthcare systems, NGOs, government, medical and public health academic institutions. So this is a really diverse group, and I love that because we have a really diverse group of panelists. So let's dive in and get started. I'd like to start by introducing Dr. Luito Edgy. And Dr. Edgy, as a family physician and someone who I know has been deeply personally as well as professionally impacted by COVID-19, can you tell us a little bit about how your experiences and expertise has driven your activities to ensure equity of access to vaccine, both in your home state of Ohio and beyond?
Thank you, Dr. Visser, for the opportunity to share COVID-19's impact. I'll start with a brief excerpt from an email that a colleague sent me in December regarding a dialogue she had with a patient. Lou, at the conclusion of our telehealth visit, we talked about recommended vaccines, including the Moderna vaccine. She placed me on speaker so her husband could hear as I endorsed use of the vaccine. She then told me that she had originally been opposed to the vaccine, but had recently participated in one of the town halls done by Center for Closing the Health Gap, and after hearing Dr. Edgy speak, had changed her mind. She's now excited and ready to get her vaccine when the time comes. She happily shared some of the data about mRNA vaccine technology that she had actually learned from the talk. Thank you for making my job easier, but more importantly, thank you for reaching out to a vulnerable patient population and working to keep them safe. We know this is more than an anecdote because stories like this are being told all over the United States, resulting in Kaiser Family Foundation data showing that those Black and Brown Americans willing to get vaccinated has indeed increased from 42% in September to 66% in December. For many of us, this has been a series of catalytic partnerships that has driven our narrative to move the needle from vaccine hesitancy to vaccine hopeful. I'll touch on 3 such participations where the development of one relationship builds on many and has created a snowball effect built on a foundation of trust. Those 3 catalytic partnerships are: 1, our clinical trial team; 2, with a local community organization; and 3, with organized medicine. First, our clinical trial team. It all started when my previously healthy stepmother died from COVID over the course of 8 really, really short days. This shook our family to its very core and catapulted me into immediate action. I knew that I absolutely had to be part of the solution to this pandemic. I knew as a Black practicing family physician working at the University of Cincinnati Medical Center and College of Medicine, which is one of 90 trial sites for Moderna, I could contribute in two ways. As a credible voice to deliver the message that vaccinations save lives, and as a credible vaccinator as a primary care physician, one of many in our nation who give over 200 million vaccine doses annually as a matter of routine. Our patients trust us to vaccinate their newborns. So I enrolled in the trial. Our primary investigator realized early on that COVID disproportionately affects Black and Brown communities. He was extremely intentional in his strategy around building his team. Internally, he hired Black, Brown, and bilingual clinical trial researchers so that they could build partnerships and trust in their communities. They formed the base infrastructure of a robust study enrollment of Black and Brown trial participants who reflect the percentage of Black and Latinx individuals in our general population. This would be important in our discussions when it came time to vaccinate those communities. They also became our boots on the ground, helping to identify blind spots in our community landscape when it comes to starting inoculations. Externally, he partnered with key organizations such as the Cincinnati Medical Association, an organization of Black physicians in our community. He presented all manner of detail about the Moderna trial, so we were well equipped with facts as we spoke to our patients. We know this is an effective strategy. Since the NAACP survey, coronavirus hesitancy in Black and Latinx communities shows that 72% of Black and 66% of Latinx Americans trust their physicians and are twice as likely to see a physician who looks like them. Second, with community organizations, closing the health gap, committed to closing the gap in health disparities in Black communities, is an organization that has also used catalytic partnerships effectively. It has built a sturdy platform to combat misinformation and is committed to making sure that no one is left behind when it comes to getting vaccines in arms. Since the beginning of the pandemic, it has held 30 virtual forums, hosting experts every 2 weeks on Saturdays from 4 to 5 p.m. It has been a same place, same time in 2 week strategy to chip away at hesitancy in an iterative fashion. Stability of its occurrence is its own reassurance. Let me say that again. The stability of its occurrence is its own reassurance. Physicians and community leaders regularly staff those sessions, acknowledging horrific historic truths of clinical studies, atrocities, dispelling myths, and translating complex science into simple fact. Third, with organized medicine. The American Medical Association, of which I have been an active member for many years, tweeted a short story of my Moderna trial participation. That was immediately picked up by TV stations, both local and national, catering to a full spectrum of viewers, which led me to many catalytic opportunities. Recording modules for Black churches in Columbus, holding virtual meetings for sickle cell patients in Washington, D.C., having fireside chats with business leaders in Cincinnati, speaking at troop sessions with Girl Scouts in our region, recording podcasts for 18 to 29-year-olds in Atlanta, reaching college students via campus radio stations, appearing on live TV for stations in rural America. Because we know from Kaiser Family Foundation data that rural non-Hispanic Americans are the highest hesitancy group. I have also had the privilege of being asked to provide context for the Black experience for my peers, publishing in journals such as eClinical Medicine by The Lancet. My family lost 3 more members between the enrollment that I did in the Moderna trial and the approval of the Moderna EUA by the FDA. But we have no losses since then. In fact, despite our very best efforts to get her in at the top of her age group, my 97-year-old grandmother just received her Moderna vaccine last week. Through this, I've learned that patience and respect are essential ingredients for our global journey back to health. And to lift all of us out of this pandemic and reach 70% herd immunity, no community can be left behind. I'd like to thank the CDC for your responsiveness, your equity, science-based, and transparent approach to this pandemic. Thank you.
Thank you so much. That was incredibly useful and information, and we really appreciate all of your efforts. I'm going to turn to Dr. Rhonda Meadows, and it's my pleasure to introduce her. She is the president of the 7-state Providence Population Health System. And Dr. Meadows, I know that you are carefully considering your next move to expand COVID-19 vaccinations beyond the initial group of healthcare workers in phase 1A. What strategies and partnerships are you considering to ensure equitable access to vaccine across your very, very large health system?
So thank you for inviting me and letting me share some thoughts with you. I really appreciate it. So although we talk about Providence being 7 states, and it feels large because we're talking about serving people from Alaska all the way down the West Coast to Texas, but we are both big and we are small. We are big in terms of being able to have the resources to do the advanced analytics to identify populations at greatest risk, whether they are people of color, people who otherwise are marginalized, or people with low incomes and low resources. At the same time, we also have the ability to share resources cross-system, and we have the ability to leverage for purchasing. All of those things has not only helped us be good partners for mass vaccinations, but it has also made it very easy for us to understand where we needed to do more locally focused work aside from the mass vaccinations. So when we talk about we are both big and small, we really mean that. We know that healthcare is local. We know that care and partnerships are local, and we know that advocacy is local as well. We talk about the strategy to prepare ourselves to do the vaccine administration as more vaccine becomes available, and hallelujah, it is on its way. Thank you, we appreciate that. But we have done a lot of work starting back from February, March timeframe when we first saw COVID come in. We started then the work of what I consider the 6 essential things to actually build the partnership, the trust and the respect of people in the community, because we don't just walk in with a syringe and say, hi, I'm here to give you a vaccine. There's a lot of work that gets done way before anything like that can be accepted. So if you will humor me, our vaccine effort started in February and March with basic relationship building, having discussions, having people express their concerns and fears about the vaccine, about the test, about the virus itself. It included making sure that we expanded our library of educational materials, communications, media, ways of talking to people in ways that they can appreciate and understand and when they are ready. Our outreach greatly increased in each of our local communities. We call our communities ministries because we feel that they are health ministries as part of Providence. We also made an effort to address something that was clearly making the headlines, and that was a lack of local testing in communities of color and in low-income communities and communities of all kinds of folks that normally aren't on the big radar. And then finally, we needed to make sure that we had our own house in order. We can do all of these different things, outreach, education, testing. We gave out COVID kits of all kinds of supplies, masks, sanitizers. But what we needed to make sure was that within our own house, our own health professionals not only understood what the health disparities were, the great higher disproportionate harm being done to people of color that my colleague has already listed. But we also needed to make sure that we understood our own role in implicit bias and recognized racism's impact quite clearly. And that is no small feat, but it is something, sometimes you have those uncomfortable conversations to get things moving along. We did a formal discernment process about vaccine equity for our populations, for our patients. That was actually part of our process. And then when state recommendations and CDC guidelines came out, we mapped and married them up together. Right now, all of our states are in 1B. And if you know this, then you know that 1B means something different in every state. But what has been helpful is having CDC's guidance on anybody 65 and up, right? And then expanding on there. So we have moved quite along. Where we have adequate vaccine supply to continue distributing beyond max vaccination sites, we have. And I'm going to give you some examples. Where we don't have vaccine readily available, we still have to do all of those things that I listed, 1 through 6. we still have to build the trust and have those conversations. And we talked about it's really important not only that we say what we do know, but we also say what we don't know, right? That transparency. And before we start talking about what we do know, we ask people what they think, what they worry about, and what they're concerned about, right? That's how we build a relationship. So with all that said, I'm going to share with you a couple of examples of where we've laid it out. And I'm going to tell you right now, we are not perfect, but we are definitely trying hard. In Alaska, we work really well with the state officials as well as the municipalities. You can imagine Alaska is it's a pretty big place. So we have different strategies going into different parts. Places outside of Anchorage, it's more focused on going in and doing community testing, education, and as vaccine becomes available, delivering it through mobile vans and mobile clinics. We also are doing work through our community health workers. We already had some already in place and then basically resourced up. So we can bring people who are from the community into our system and have them understand the health implications and care. We're providing not only the jobs, but also the ability for us to connect. In Washington State, a great example is our Swedish health system. They have already deployed 16 different mobile vaccine clinics. So we're hitting about 1,500 people. And the beauty isn't that they're just vaccine mobile clinics. The beauty is that the vaccine clinics are going into neighborhoods based on our data. We know exactly where they need to be, right? And we know exactly where the patient volume is going to be. And that is really, really important that we continue to do that. In Northern California, our focus has been on migrant workers. It's also been on the tribes in Humboldt County. And so we're reaching out to not only the community leaders there. You start with the community leaders and build trust and relationship. We started with, again, the COVID kits, the testing, the outreach, the education, and having explaining, and then partnering with FQHCs, rural clinics, and then basically providing our own health professionals in a volunteer mode to kind of supplement where they need the help. Southern California and Los Angeles is a great example of bringing in our religious organizations. We have partnerships with 18 African-American churches in LA, started the same way, education, relationship building, testing kits, and then started with our first vaccine clinic, serving 250 people in one day. That may not sound like a lot of people, but if you continue to do that on a consistent basis and do it with more partners, you gradually make your way through the communities that may not otherwise receive those services. We are a large healthcare system, but we are also an owner of Providence Health Plan. And our health plan is also accountable for addressing equitable vaccine distribution. They're not given the shots in the arms, but they are, however, doing the outreach to their care managers. We already know the high-risk populations. We basically adjusted how they identify them to include all of the risk factors for COVID itself, and that actually helps inform our outreach to them. Our nurses, social workers, et cetera, reaching out on a regular basis to them. We have also offered to provide non-emergency transportation for both Medicaid and Medicare recipients to vaccine clinics, whether it's a local clinic or a max vaccine site. So we're basically kind of trying to address the transportation difficulties that people have. We have home and community services, which includes our skilled nursing facilities, and most of those residents have been taken care of. But we've expanded to our PACE program and our home care patients, as well as the people who live in our low-income transitional housing. And then I was going to say finally, but it's not really finally, our own employees, right? Our own caregivers. Right? We had to take a long, hard look at who we have on our team already and look at them and understand that there are health disparities within our own employees. So whether we're looking at environmental services, call centers, home health aides, the same extra effort, the same extra work that we do to ensure health equity in our general population, we apply to our family as well. Thank you.
Great. Thank you, Dr. Meadows. And based on your comments, I completely understand what you mean by you are both large and small. That is a ton of work and a great geography that you're covering, and a lot of variety in the strategies that you're taking. So thank you so much for running through that with us. And I can't wait to talk more in the dialogue and discussion. But for now, we're going to move from the West down to the Southern United States. I'd like to come to Chancellor Ghali. And as we heard on the first day of the vaccine forum, building trust really requires awareness of and sensitivity to community concerns. And I know that much of the work you've done in the past few months has been very proactively considering these current concerns in your community and across Northern Louisiana. So what are some of the strategies that you've used as Chancellor of the Louisiana State University Health Sciences Center in Shreveport to stay connected to the communities that you serve?
Thank you, Dr. Visser. It's certainly my honor to be here with such an esteemed group of clinicians and researchers. And I really want to thank the CDC for putting this program together. And wow, I'm just happy to be here. Let me just tell you. I think really three things. One is trust, one is collaboration, and one is resiliency. And I think to some level, the speakers thus far have really touched on all these different areas. But let me tell you how we developed trust here. And again, we still have a bit of a ways to go. We had an existing program here at the LSU Health Science Center in Shreveport, which is a large academic medical center. We have a cancer center, the Feistweiler Cancer Center. And in the Feistweiler Cancer Center, we had a program called Partners in Wellness. It's a very long-standing and trusted community outreach program within our Feistweiler Cancer Center. But it was originally primarily aimed at screening for breast cancer, providing mammography and things like that. So these vans would go all over the rural and underserved areas of Louisiana, of which we have a lot. We first began using these vans to do the diagnostic testing for COVID. And the reason was there was already a developed trust. The folks in these neighborhoods were used to seeing this van and they already had an established trust with it. Then what we did was we simultaneously began to develop our own test using RT-PCR technology and our very robust virology department here. And we did that with the help of the Louisiana Department of Health, and we did it with the help of Governor John Bel Edwards. He ended up signing an executive order, which then allowed us to establish this emerging viral threat lab with the help of CMS and others that were involved. So because of the trust that initially was developed in the Partners in Wellness, we were able to develop this EVT lab, Emerging Viral Threat Lab. Then this allowed us to develop testing strike teams made up of clinical trials nurses, regular nurses, students, and things like that. This then led to the development of drive-through testing, which then led to the development of drive-through vaccination sites. All of this was developed within these underserved areas, primarily, both underserved from a population, rural standpoint, and underserved from a racial standpoint. Now, collaboration really was key number two. And we collaborated with other academic medical centers. I won't name them all because we did with many of them, with other healthcare systems in our region, as well as at the corporate level. We also collaborated with state governments, the governor, the Department of Health, with houses of worship to develop trust, with the state legislature. I had several state legislators come up to me and say, you know, you're doing pretty good in certain areas, but we need to get you set up in the predominantly African-American churches. We went to those churches, we set up, because we had pre-existing testing there, it was the natural site to use and dovetail that into the actual vaccination distribution and getting shots in the arms. And for the sake of time, I want to move to number three, which is resiliency. And the resiliency is, look, if the tests at the federal and state level are taking a long time, be resilient, make your own test, particularly if you're an academic medical center. If it's not an approved diagnostic lab, collaborate with the state to get it approved. If there's no testing supplies, what we did was we created our own swabs, our own transport media. For the lack of community buy-in, we created and dispensed the so-called goodie bags that we would do the test, provide a goodie bag that had things like the hand sanitizer, like masks, like gloves, and things like that. We engaged the community churches, and it created role models at all levels. We never gave up. When the variants began surfacing, we began doing rather significant genomic sequencing here, and we've sequenced over 2,000 viruses. And recently, the Q677H and the Q677P were identified here. For those individuals that had no internet or no transportation, we created registration sites or sites for vaccination that didn't require registration. We would pick up people, we would transport people, we would work with the local churches, we would work with individuals that had daycare issues. So I really think a combination of trust, collaboration, and resiliency is the key. And so I want to thank you guys, and I'm happy to entertain questions later on. I'm just honored to be on this esteemed panel. Thank you so much.
Thank you so much, Dr. Ghali. I love that you've given us 3 very concrete things to be thinking about: trust, collaboration, and resiliency. So thank you for that. I also, it's really amazing to hear all the work that you've done, and particularly how you've leveraged the work that's been done for testing and the infrastructure as we move into vaccines. So thank you for sharing that, and maybe that'll be helpful to others as they think about their own systems, as well as working with the houses of worship and other healthcare entities. So thank you for all that. So I'm going to turn now and remind us all that as we think about this forum and as we think about this partnership and building these bridges between public health and healthcare systems, that we really need to maximize every aspect of the healthcare system. And so I'm going to turn to Dr. Kaufman, and you as the state emergency EMS director for Indiana. I know you've worked closely with the state Department of Health and Human Services to do just that and reach those in your community who might not otherwise have been vaccinated. So can you tell us a little bit about your experience, particularly around how EMS balanced the vaccination role with the role of providing continued care for hospitals? So thanks for being here, and we're excited to hear.
Yeah, absolutely. Thanks, Dr. Mini Delman, and thanks to the CDC for having me on. I'm truly honored to be here with this great group of panelists. So I'm an emergency physician, and I am our state EMS medical director within the Department of Homeland Security. And as such, I represent more than 25,000 EMS professionals. Those are the paramedics and EMTs that typically respond every day to 911 calls for emergency assistance. But you've heard already a little bit about building bridges between public health and healthcare, and I'd really like you to think for just a minute that EMS, our EMS professionals, are already doing that in so many different capacities. And through that, I want to share with you a program that we've built here in Indiana. But know that our EMS professionals across the entire country are available 24/7 with a community presence in nearly every community across our country. We're highly skilled, very well trained. We're a mobile workforce. We typically reside within our fire and our EMS industry. And we truly do stand at that intersection of public safety, public health, and healthcare. So thinking about vaccine equity and a population that is often forgotten, those are our homebound individuals with chronic medical illnesses or developmental disabilities. This new program is really a wonderful multi-agency collaboration that spanned Homeland Security, which oversees and provides clinical guidance to EMS, our State Department of Health, our Indiana Medicaid, our Family Social Service Administration, and our local public health departments and our EMS agencies, and really numerous other key stakeholders. But at its core, our Homebound Hoosier program, as it's called, is designed to get COVID-19 vaccine to those Hoosiers that otherwise would not have access to really what is a life-saving treatment. The program matches available vaccine that's found in our local health departments with identified homebound individuals in surrounding areas, and then utilizes those community assets that are already available in our EMS agencies in those communities to deliver vaccines in the individual's home. I really like to think of this as a perfect partnership of public health, public safety, and healthcare to all work together to deliver non-emergent care in place to persons in their communities, in their homes, in an effort to improve overall personal health and safety. At the end of the day, that's the function of our EMS and fire industry, is to promote and protect personal health and safety. This new program, this new concept is not really new in nature, and it's otherwise known as community paramedicine, and was in fact one of our governors, Governor Holcomb's top agendas for his public health pillar in 2020. So homebound Hoosiers are identified by our Family Social Service Administration's local area agencies on aging. That is part of our Division of Aging. And when they're identified as needing vaccine and not having access to, in any way, shape, or form, to get to one of our vaccination sites, they're entered in the portal. And I want to be clear that these individuals must also meet our State Department of Health's vaccine eligibility criteria. We've currently opened vaccine to individuals 60 years of age and older, and with some chronic health conditions. And I'm super proud of our health department. As of today, we are very close to having administered almost 1 million vaccines across the state of Indiana, and that's for a population of about 7 million. So they're really doing a tremendous job. As vaccine becomes available from those local health departments, and this might be through appointment cancellations or no-shows, or it might be that extra dose that's left over at the end of the day in that vial that they had to open for the last couple patients, that vaccine is then matched with a recipient on our Homebound Hoosier portal. EMS provider agencies are then engaged in those areas to respond to the local health department, obtain the vaccine, deliver it to the individual in their own residence, administer it, and then observe for any reaction that might occur. While vaccine supply currently is quite limited, the program has been very well received, both here at home in Indiana and frankly across the country. We've provided overviews of this program like I'm doing here today with you all. In addition to that, we've spoken with FEMA and provided an overview of the presentation of our program to the Region 5 states. And we've had numerous other states reach out to us through organizations such as the Association of State and Territorial Health Officials. As the vaccine supply continues to improve, we do anticipate that this program will continue to expand and ultimately be able to reach more homebound individuals. All of our state agencies and stakeholders are truly just humbled at the support and enthusiasm that the program's generated to reach really one of our most vulnerable populations throughout our state and across the country. And the program fits very nicely. If you all had an opportunity to look at the Biden-Harris administration's COVID vaccine strategy, page 44 specifically mentioned reaching out to EMS provider agencies and organizations within your own communities to help deliver this vaccine. I really loved what Dr. Meadows said a little earlier today when she said that we're not perfect, but we're trying very hard. And I thought that quote was so fitting, as we really are building those bridges between healthcare, public health, and public safety, and using an asset that's already there, already available in every community. Creating these partnerships has really gone a long way to help get vaccine to those in need. And my auto dimming lights are playing tricks on me today. So no, thank you so much. I'm really happy to answer questions about the program and provide any additional guidance so that other states might be able to replicate what we're doing here in Indiana.
Thank you, Dr. Kaufman, and such a great example of the health system working across, using an underutilized in this particular situation healthcare resource and bridging over to public health, working with the Secretary of the Department of Health and Human Services to develop this really innovative Homebound Hoosiers program. And it has been really fabulous working with EMS in my deployment over the past year, and I've really found them to be versatile, specialized, and scrappy, right? Like when you put those three things together, you can accomplish so much. And so such a great innovative program, and I'm just really enjoy hearing about it. So thank you so much.
Thank you.
And now I'd like to move to our final panelist, Dr. LaShawn McKeever. And as Director of the Office of Minority Health at CMS, I'd like to turn to you and ask, part of CMS's mission is to ensure that vaccines available to a large portion of the United States population at no cost. And that is a really unique role. So as Director of the Office of Minority Health, tell us how this role helps us as a nation address equity in vaccine access and what challenges remain.
Thank you so much, Dr. Visser, for that question. And I'd like to start by saying really a special thank you to the CDC for convening this. As others have echoed, this is such an important conversation. And just by the comments that have been made by the panelists today, I know I'm learning something about things that I can take back to CMS And I hope to share some things about what we're doing at CMS that would help drive this conversation as well. So as you said, my name is Dr. LaShawn McKeever, and I'm the Director of the Office of Minority Health at CMS. And our office focuses on meeting the needs of underserved communities, and that includes racial and ethnic minorities, rural populations. So we heard a little earlier about some of the unique challenges for rural populations, for people with limited English proficiency. This is, there are many challenges for people accessing information, and we talked about trust and what that, how that translates into people's ability to access the things that they need. We also focus on sexual and gender minorities and people with disabilities. So for that first part of the question regarding what is CMS doing to ensure equity in vaccine access is a critical one, especially for our office and our target populations. As the largest health insurer in the US, CMS plays an important role in ensuring the vaccine is affordable and accessible for our enrollees. And this is an important, one of the most important things that CMS is doing to support equitable access to the vaccine. As many of you know, cost is often a tremendous barrier for many underserved communities to accessing care. However, whether an individual has Medicare, Medicaid, private insurance, or no insurance, there is no cost to anyone to receive this vaccine. So this is one very important way that CMS is ensuring equitable access to the COVID-19 vaccine. And we're using the many different ways that we communicate across the country to get that information out. In addition, healthcare providers play an important role in ensuring equitable access, and CMS is committed to ensuring they have the necessary tools to respond to the COVID-19 public health emergency. We've released a set of toolkits for providers, for states and insurers to help the healthcare system prepare to administer the vaccine. We know that there are many challenges across the country as at the state and local levels. Communities are trying to organize to get this vaccine out as fast as we can. And so making sure that there are proper resources to help people understand how CMS is providing support to do that. These resources are designed to increase the number of providers that can administer the vaccine and ensure adequate reimbursement for administering the vaccine. The second part of that question regarding what challenges remain is also an important one. Through our outreach to stakeholders across the country, we're still finding, as others have commented and has been discussed throughout this event, that there's a strong hesitancy to receiving the vaccine, and distrust of institutions, including the government, is one underlying factor. So we are working to build vaccine confidence through engaging healthcare and community leaders to build trust and increase collaboration through hosting listening sessions at our national level, at our regional level, and working truly to engage with partners on problem solving for this critical issue. One example is addressing vaccine hesitancy among healthcare workers in the nursing home setting, where we know there are many vulnerable populations there. We have much work to do, and as we're continuing to partner with our stakeholders, like many of you in this town hall, this will be necessary to address this challenge. I think earlier it was Dr. Edgy who noted moving from vaccine hesitancy to vaccine hopefulness. That really resonated with me, because that is what we're trying to achieve collectively. In addition, educating our beneficiaries on remaining vigilant about fraud during this time is another challenge that we're addressing. So as we as a nation are attempting this massive effort to vaccinate Americans across the country, unfortunately, there are those who are trying to take advantage of this in fraudulent ways. And so, Medicare covers the COVID-19 vaccine at no cost. And we're continuing to remind our beneficiaries that if anyone asks them to share their Medicare number or to pay for access to the vaccine, that is likely it's a scam. And so we want to make certain that our beneficiaries know that you can't pay to put your name on a list to get the vaccine. You can't pay to get early access to the vaccine. if someone calls or texts or emails them promising access to the vaccine for a fee, not to share their personal or financial information. So if you think about, our role in ensuring that everyone receives this and understands there's no cost, we want to be to protect our Medicare beneficiaries and their personal and financial information in this context. One additional question or thing that I would like to address is how we're leveraging the existing system to communicate to providers and patients about the COVID-19 vaccination programs that are happening across the country. We are working diligently to educate providers and facilities, beneficiaries, and their families to understand COVID-19 vaccination. So through our social media channels, we're educating communities about vaccine safety and coverage. We've established a COVID-19 vaccination page on cms.gov to provide accurate educational resources and materials for the public that complement the CDC's COVID-19 vaccine pages. And as I mentioned earlier, we're holding a host of reoccurring stakeholder engagement sessions to share information related to the agency's response to COVID-19, which are often intended to provide updates as well to share best practices among peers and to offer attendees an opportunity to ask questions of CMS and other subject matter experts. So there's a lot of work being done. Again, I'll reiterate that one of our main ways of ensuring equitable access to the vaccine is making certain that people know there is no cost for the vaccine. And for those who are here today, if you can help us in promoting that message, that is one of the barriers. Costs, people being fearful of what it may cost to get vaccinated. And so that's something that we can certainly, hopefully collaborate on. So thank you.
Thank you so much, Dr. McGeever. I really appreciate it. I think this issue of not only providing the vaccine at no cost, which we greatly appreciate, also protecting our seniors from, what you described. It's just sad that there might actually be people out there that, could try to benefit from people not knowing that it's a no-cost vaccine. So thank you not only for all the incredible work that's being done at a federal and a regional level, but also for protecting our seniors from other types of fraud that exist. I'm going to move us along to our speaker dialogue questions. So the next two questions are specifically for Dr. Ghali and Dr. Edgy. So what lessons would you offer, concrete lessons, for our public health department audience, specifically on how to best work with healthcare systems to form vaccination partnerships or new partnerships? So your work really, I think, speaks to this, and people I know are looking for concrete ideas.
Absolutely. Thank you for that excellent question. One of the things I would certainly recommend doing is find out exactly what existing relationships are already there. And as we all know, there are usually several health systems in one community. And so if there is a unified entity, for example, in Cincinnati, we have the Health Collaborative, which is sort of a neutral convener committed to the health of our institution, all of our institutions and our entire community. That's one place to start. It does decrease the duplicative nature of our work and prevents us from having to redo a lot of different things. So that's one thing. The second thing I would just make sure is that you're flexible. Working together may actually require that you utilize your resources in ways you didn't expect in the beginning. So please be flexible.
Sure. Great comments. I would briefly say that, I think you have to create whatever model fits your locality. I mean, look, there's not going to be a perfect answer for this. But I think the one key for working with the between the public health and the larger hospitals and things like that. Hospitals really aren't greatly set up to deliver the vaccine. At least here in Louisiana, they're really not. And I think finding an entity in whatever that entity may be in your region and collaborating with them, because the biggest thing that I see, and next to trust, is convenience. we have to make the administration of the vaccine convenient for the folks. Otherwise, they're not going to do it. They're not going to go trample through an academic medical center that takes them an hour to park somewhere to find a place to go get a vaccine. I don't care who they are. So let's make it convenient for them. So that would be the biggest thing that I would say is convenience. Work out a model that makes it convenient for why we're here, and why we're here is for the patients.
Yeah, and Dr. Ghali, I mean, I remember your in talking to you initially, you know, this image. I'm from Chicago. I'm a Chicago born and raised girl, and there is a church on every corner, and our communities are grounded in their churches. And this is what they know, and they trust their church leadership. And I remember you telling me about the little old lady coming down the street with her walker, coming to church, you know, to get that vaccine. And it speaks exactly to what you're saying. Convenience is extremely important, but it intersects with trust, right?
It doesn't. You got to target a certain population that you're trying to achieve that goal for. We got help from the Alpha Kappa Alpha sorority when we were trying to get the word out into the African American community. I mean, it's our responsibility. It's not the patient's responsibility. It's our responsibility to make sure that the vaccination is equitably distributed.
That's great. Thank you so much. So our next question, I'm going to pose this question to Dr. Meadows and Dr. Kaufman. And I know, Dr. Meadows, you are on the precipice of moving into that 1B phase and really considering you know, how you're going to take lessons learned and apply them. And Dr. Kaufman, in the same sort of watching that eligibility category explode. You know, what have you learned over the past year, both of you, that will inform your work in these coming months as vaccine is rolled out and that eligibility group expands? Let's start with Dr. Meadows.
I'd say probably number one is a reminder to not be arrogant and think that we can do it all ourselves. That's what partnerships are all about. And actually, people are sort of much better by doing that. We are not limited to traditional partners either. We can be innovative, we can be creative, and it's amazing how well those creative partnerships actually perform. The people in our individual communities appreciate it. They're coming to another trusted partner. It makes it much easier. The second thing is when we talk about vaccine hesitancy, I remind people that we had longstanding health disparities anyway, and all the issues that cause that have to still be taken into account when we are addressing getting vaccines to people. So the hesitancy piece, no joke, it's definitely a problem. But access, quality of care, compassionate care, follow-up care, and answering questions is really important. And then finally, the vaccine clinic is not just having it local is really important. I'm right there with you. Also, having some staggered times would be really helpful, right? People who are working an hourly wage may not be able to take off during the vaccine clinic times. And some people need to have off hours, weekend hours, et cetera. Otherwise, they lose pay or they lose their job. So.
Great points. And Dr. Kaufman, what about you? What have you learned?
Yeah, thanks, Dr. Visser, for that question. That's great. You know, you've really got an insightful group of panelists here because so many of the same comments that have already been mentioned are just resounding in my thoughts and in my words as I'm sharing our experience with you over the last year. And that's partnerships, that's planning, that's preparation, and that's being flexible, right? So with partnerships, you mentioned, and I believe this came from Dr. Ghali, the story about the churches on being on every corner, and you know, EMS is in every community, and there's a fire department in every community. Even if that's volunteer, you've still got trained EMTs and paramedics that are skilled. And you know, EMS started as a way just to move people very, very quickly, but the care that we deliver has evolved so much over the last 50 years that we really are now providing healthcare at the patient's home in their community. So leveraging those existing partnerships that are already there will really go a long way. And on the planning side, it's using those assets to the fullest extent their capabilities. And what do I mean by that? Early on in this pandemic, we identified a need for ventilators and a potential shortfall in our healthcare system. So we started cataloging and inventorying ventilators on our ambulances across the state of Indiana, and we came up with an additional 500 ventilators that were able to be leveraged and utilized for patients in the hospital by partnering with EMS. And a lot of those partnerships do already exist. EMS brings patients to hospitals 24 hours a day, 7 days a week, and they likely already know individuals in their community who they've responded to more than once for chronic medical conditions who are likely homebound. So planning those types of assets. We also identified a need early on for additional vaccinators. So we expanded our scope of practice to allow our EMTs who already had that skill set. We expanded it to allow them to be vaccinators. So planning, preparation, and flexibility. Even the best laid plans often need to be manipulated or changed at the last minute. And that's the one thing I think that COVID has taught us to do very well, is just be nimble and flexible.
Thank you both for those comments. I'm hoping folks out there listening are taking some of these to heart, because I think there are many opportunities that may not have been fully explored. So thank you both for your comments. I'm going to move to some questions that we've received from participants. So the first is Sean from Oregon, and he asks, what methods have you found helpful in connecting different health systems to provide an overall equitable approach? And I'd like to ask Dr. McIver to weigh in on this, because I know both at a federal level, but also at a regional level, CMS has been engaged, and you talked a little bit about that, but it would be helpful to think through, with you, sort of how that's happening, because health systems obviously are very different. So would be curious your thoughts on that question.
That's a wonderful question. When I think about how to frame that, from CMS's perspective, we serve as a true connector in the healthcare system. So, I talked about earlier how CMS is the largest payer of healthcare in the country. And so we have we have deep connections across the healthcare industry, and our ability to connect to stakeholders at many different levels within healthcare is a critical part of our ability to help connect healthcare systems. And so, I talked about as well that we have really adapted. As the pandemic has progressed, we've adapted how we are working with our partners, how we're collectively problem solving. And CMS has that ability to bring partners across the country. Someone mentioned there's a large and a small part to what you're doing. I think it was Dr. Meadows. We're a federal agency that has a large footprint in the healthcare system, but through our regions, we have that ability to touch local communities, and finding ways to connect stakeholders across the healthcare system in that way has been an important role that we're playing, because we're uniquely positioned in the healthcare system. So that's something that I would offer for that question.
That's great, thank you. And we have another participant question, this one from Jean from Georgia. And this is really for any of our panelists who might like to answer this, but just how can a jurisdiction rapidly build networks to efficiently disperse vaccinations? And I stress rapidly, because here we are in a place where the difference of a day could mean whether or not you're exposed and contract COVID. So how can a jurisdiction rapidly build those networks and through that address equitable vaccine access?
I'd be happy to speak to that question just a little bit. When we talk about jurisdictional boundaries, we talk about leveraging those relationships. Again, I think that our public safety organizations that are found in our EMS and fire industry really provide a great partnership to do that. So I would say leverage those already existing relationships. As I commented on a little bit earlier, our EMS personnel, our emergency medical services personnel, are bringing patients to hospitals every day. A lot of states, a lot of territory, they've already helped to better define those relationships through things such as local healthcare coalitions, which in our state involve public health, healthcare emergency management, and emergency medical services. So leveraging what's already in place, it really prevents you from having to recreate the wheel, and can get those assets into the vaccine, frankly, into people's arms very quickly. We know that, for example, when a vial of vaccine is opened, we've got about 6 hours to administer that. So working with our EMS industry, who's already poised with personnel, with assets, with response capabilities, with communication, it's a logical partnership. So that would be my advice, is to leverage those already existing relationships to their full potential.
And Dr. Kaufman, just to tee off of that a little bit more, I'm wondering, you mentioned that you had a few policies in place, and the community paramedicine, initiatives that were moving in your state that set you up nicely for being able to make some of these initiatives take in the community quickly. Do you have any advice for folks who might be listening about how to make some of those initiatives happen? How to poise a community or a state so that they can, make these really innovative moves when the need arises?
Yeah, just to give you an example of that, Dr. Visser. So before the pandemic started, we had already started to work to expand our scope of practice, so that we have about 5,000 paramedics and advanced EMTs in the state of Indiana. They can give IM injections, they can give vaccinations. Traditionally, that's not been a skill that our EMTs have been allowed to do. Through a shortage of epinephrine auto injectors about 18 months before the pandemic, we opened up our scope of practice to allow our EMTs to do that. So we had already provided, I like to call it just-in-time training on IM injections, on monitoring and observing for allergic reactions. So when the pandemic came around, it was really a relatively easy lift to be able to expand the scope of practice to include them. So that took our vaccinator pool from 5,000 EMS professionals to 20,000 EMS professionals.
Wow.
So it's things like that. And we had been working with our state office of Medicaid to put together a reimbursement program, because traditionally EMS has to move a patient in the back of an ambulance per loaded mile to be able to get reimbursed for the care that they deliver. Through some really forward-thinking officials, particularly Dr. Sullivan in our state office of Medicaid, she had been working on a program that would allow EMS to get reimbursed for care delivered on scene, even without transporting the patient. That becomes important as we start talking about being able to give vaccines and cover the costs of their operations and the cost of delivering those vaccines in homes. So any existing policies or protocols or orders that exist, leverage them and use them to help mobilize your industry and your professionals during a pandemic.
That's such a great example of an integrated system. So thank you so much for sharing with us.
Can I add?
Please do.
So, Dr. Kaufman, that was absolutely fabulous, by the way. I kind of would like to add that the more preparation we do with having our partnerships solidified and revived, and when they're ready to receive the vaccine, the smoother this is going to go, right? So he just described an amazing network that could actually get to people right where they are. But we also have the local pharmacies, the family pharmacies. We also have home health care services that can actually make it out there. We have armies of people that may seem siloed, but could be activated to get vaccine out in mass ways without people going to mass vaccine sites. They're there. There are so many people who are trying to help. We just simply need the hub, the organization, and more vaccine.
I just wanted to mention that at the University of Cincinnati, we have 688 residents and fellows who have been able to take advantage of the CARES grant. And actually, it started off as a test and protect program where they were able to go ahead and be deployed to do some testing. But the infrastructure was laid, and they have been mobilized across multiple specialties to go ahead and actually pivot into being vaccinators. So that's been an awesome opportunity, and I'm just really, really proud of our residents and fellows.
And I would just add, there's a recognition having partnerships in place is helping with our ability to be nimble in our response. What we're hearing from stakeholders as well across the country is that there's still so many more in the wings waiting to lend assistance in this effort. And so, I would encourage individuals to think about who may not be at the table that you have those that you generally bring to the table, but what voice is missing, and what partner that you may not have traditionally considered for something like this should be at that table. We heard in a recent listening session that there's a lot of organizations that are willing to step in and help. Now, there are barriers as well for some of these organizations. They're doing some great things in their communities, but their resources, there's an issue with resources in helping to address something of this magnitude. And so being able to partner possibly with groups that can help you penetrate into communities that may be harder to reach is something to consider, because they're waiting. And, I was just so touched to hear the number of organizations, big and small, that have not been yet brought to the table, but are willing to do so.
So we have some mental health clinics. We've got some just disability, local providers that they're waiting for someone to pull them in, and they're more than capable of helping us get to where we need to be. Same thing with food banks. Same thing with homeless shelters, right? They're sitting there, and it's amazing how creative you can be. I think one of the food banks, we actually have a place where they had empty office space. Well, guess what? It's now a clinic. And it's being prepped and it's ready for our health professionals to come in and volunteer to provide the vaccines once the supply is there. It's amazing how well people can be creative, but it's even better when you realize the strong commitment and the big hearts they're bringing. They really want to do this. They simply need to be coordinated in.
Thank you for that. And we've sort of addressed some of the comments we've just made, some of the thoughts of the last participant question. Jessica from Kentucky was asking, I like the topic of building bridges between public health hospitals and the medical industry, but what about building bridges among supportive services as well? And I think we've hit on a lot of ideas here, whether it's home health aides or, some of the other ideas that were brought up. And of course, the model of EMS. Are there other supportive services that you're aware of or that we can suggest? I mean, I know there are barriers and there are limits to the number of vaccinators, but are there other supportive services that you all are thinking about? For example, I don't know if urgent care clinics, how many of them that are outside of hospital systems are actually planning to or have the capacity to do vaccination. So that's one thing that popped in my mind. We obviously see long-term care facilities and we see pharmacies, but I think trying to think about, there's a lot of people who want to help, but what's sort of the easiest to do that has the least barriers currently to sort of, how do we think really truly outside of the box? So are there other ideas beyond what was described here? Because I want Jessica's question to be answered.
So we're using our urgent care centers and our express care clinics. And we've got a couple hundred of them across the 7 states. They are in queue. They're just waiting for the supply. The health professionals are there. They're educated, they're trained, and they are sitting there like this, waiting for someone to come to give them the supply so they can actually help out. And I don't think we're unique. I think that there are other health systems that are doing the same. They're using not only their primary care clinics, but they're using some of their specialty clinics, urgent cares, express care clinics, any kind of ambulatory, even our ambulatory surgical centers, right? We have some space off to the side. So it's a matter of having the supply and again, coordinating. What we don't want to do is duplicate efforts on the same street corner, right? But making sure that when we're working in coordination with other health systems that are also in our same geography.
And I just want to make another plug for the family physicians out there. We are ready and able, trained. We do this every single day. Patients trust their babies to us. And, we, as I mentioned before, routinely give 200 million vaccines every year. And so we are well poised to be able to be members of the solution.
I'd like to say that I completely agree with that. And another thing is, don't underestimate the capability of a group to do something. And the reason I mean, certainly, I mean, I would still love to find someone that can give a virtual vaccine, virtually through, telemedicine. But maybe that's the next step. But one of the interesting things is just take a step back to when we were talking about testing and setting up the test kits. At one point, we were making our own test kits, and we sort of became overwhelmed with that. But we were able to get the Louisiana Association for the Blind to put the test kits together. So we would make the swabs and they would put the test kits together. So don't underestimate that ability. And also we'll mention to Dr. Kaufman that we here in North Louisiana got the EMS folks to vaccinate a majority of their fellow Louisiana State police officers.
Mm-hmm.
So 100% right.
Yeah, that's another great example. And I think a lot of these neat programs that you've heard about today, they don't have to exist in a silo on their own. They can be combined with some of the other great programs that you've heard about today. And one example of that was back in October, then when we knew that COVID vaccine would be coming, we wanted to kind of get some of these groups together. So we went to our largest EMS provider organization in the state of Indiana. It was Indianapolis EMS, and we worked with them to set up a flu vaccine clinic at one of our local community centers in the Indianapolis area. And so not only was the EMS agency there giving vaccine, but we had some of our state Medicaid office there doing social determinants of health questionnaire. We had our healthcare systems there so that they could get people aligned with primary care physicians in their communities. We had another organization there that was preparing hot meals to help feed the community. And it really turned out to be a community event, but it was just an example of taking a lot of different programs that existed on their own in a silo and bringing them together to really help fill a need and help pave the way for COVID vaccines. So.
Yeah, and Dr. Kaufman, one of the things, just to key off something you said there, we have at the front of the line, oftentimes the folks who are there on multiple cell phones and laptops trying to get their loved ones who are in eligibility categories vaccinated, right? And they are eager. I admit to being one of them. And we've got folks, really trying to press, but some by utilizing these supportive services and utilizing these unique strategies that we've been talking about throughout the last hour and a bit, you're getting to people who probably thought they would never get a vaccine. Isn't that right? Right, like in your particular story, these are folks who may not have thought that they would be on the list. They would not be in line to receive a vaccine.
Yeah, that's right. And along those lines, early on in this process, we have a solitary state database for registering and recording vaccine, and that's really to get to be able to navigate that. It can be very difficult for seniors, folks who aren't as technologically savvy at using computers and getting on the internet. So we engaged our local area agencies on aging. That's part of our division of aging within the Family Social Service Administration, to start making phone calls and really they used their own database of anyone who's ever had a touch point with some type of social service. That could have been a Meals on Wheels, it could have been transportation, it could have been some other aging or in-home service. So those are the individuals I think that you were alluding to that might otherwise never have been reached. So being able to call them, identify them, and put them in a database to receive a homebound vaccine has really meant a lot to those individuals.
That's great. All right. Well, I'm going to move us on to what we're calling the rapid fire final question for each of you. And just take a minute or two. We don't want to rush you but by the title, but I do think it's really important for us to really personalize the work that we are doing here. And so I would like for each of you, and we'll go in order of the presentation. So we'll start with you, Dr. Edgy. And just I'll ask you, what does a COVID-19 vaccine mean for your community or organization, even you personally? So we'll start with you, Dr. Edgy.
So as I had mentioned before, I have had losses in my family, and I've got places at my dining table that will not have a person in a chair. What I want to make sure is that nobody regrets their decision not to get a vaccine. And also that those of us who are working on the other side, trying to get people vaccinated, that we examine ourselves every single day to determine how robust our response has been so that we don't have any regrets at the end of this pandemic. We want to give 110% every single day and not lapse one single day until this is over. Thank you so much for having me. I appreciate it.
Of course. Thank you so much for being here. And moving to Dr. Meadows, same question.
So I'm going to tell you that the vaccine actually means that there's a chance of, reduced loss of life and a reduced loss of health for my family. I have actually reached a point where we have lost 10 family members since March from COVID. And when I talk to my family members now about the vaccine, some of them are starting in the hell to the no box, and I understand what they're worried about, but I remind them about the greater risk that the virus itself is the harm that it's doing to us is just beyond belief. So when I go out and talk about the vaccine, I've had the vaccine, I speak about, you got to weigh the risk of the things that you were worried about. They're not going to dismiss them because bad things did happen. Bad things happened in 2020, and I can understand the concern. But the virus itself, unchecked, will keep us prisoner if we don't have the vaccines to develop the immune response that we need. So I'm going to stop there, and I'm going to thank you all for including me and letting me join you today.
Thank you so much. And Dr. Kaufman.
Oh, wow. You've heard some great responses already. Gosh, I think that the pandemic has been very impactful in ways that we are not going to fully realize until later, right? And so I mean by that, you know, the masking, the social distancing, the 6-foot barrier between people, it's really prevented, I think, a lack of human connection. You know, whether it's being in an ambulance and being able to look at a patient with your eyes and see a smile, or being able to touch someone and shake their hand or give them a hug. So I think that the vaccine means some degree of return to just basic humanity and being human. And that's certainly on a personal level. I think on a professional level, that the vaccine means that public health in our nation will never look the same as it has in the past. It will take a completely different role with completely different participants, including emergency medical services, but it will fundamentally change for the better the way that we reach out to citizens, to folks in our country and really around the world, and the way we care for each other.
Thank you so much, Dr. Kaufman.
Thank you.
And Dr. Ghali.
You're making me follow all these great people. I'm not sure I can handle all this. Look, you know, what does it mean? I mean, I could say all the right things, right? I could say, oh, it's going to create herd immunity and it's going to bring us back to normality and everything. But the reality is what it's going to do is that it is going to allow, particularly in the more vulnerable populations, to close the loop on trust with the public health system. This will close the loop. This vaccine will prove in modern days that we care about all of our citizens, regardless of race, color, or creed.
Beautiful. Thank you. And Dr. McKeever.
Thank you. I'd like to echo what everyone has said about just really being honored to be a part of this discussion today. And also thank you for giving us an opportunity to say, you know, personally what this means for us. You know, for me, having a vaccine really is about hope, and protecting and saving communities that, you know, every day I get up and I'm thinking about the lives that we're responsible for through our Office of Minority Health, and how this vaccine represents hope to end the devastation that is happening in our communities across the country. You know, we saw early on how, as we reached the vaccination stage, there were healthcare providers in our nursing facilities who were very hesitant to take the vaccine, and we're still working through that. but some of those same individuals come from communities, that look like people that look like me and the people that I love. I haven't lost family of my own to the vaccine, to the pandemic, but it's all around me within my own personal circle. I've seen the devastation of this public health emergency. And so the vaccine, for the first time, I think is really giving us hope that we can stop this, that we can bring back the humanity that was mentioned. So again, I'm just thankful for this opportunity to talk about our role in this and helping to make sure people know there is no cost for the vaccine. And that's a message that if we can all take back, I think will be important. So thank you so much for this opportunity.
Thank you so much, Dr. McKeever. And I agree, just to punctuate a couple of things that we've heard, the vaccine is a massive public health triumph. It is an incredible achievement that we are at this stage right now and can offer free vaccine to protect all human life. And cannot wait until my 3 daughters can also receive vaccine. But in the interim, I will certainly roll up my sleeves up and accept that vaccine in the hope of protecting others so that we can gather again and grieve together and gather again and celebrate together. Those are 2 things we have lost. And I've lost 3 uncles and have had to, nurture my mother through grief when she could not attend her own brother's funerals. This has been a horrible hit to all of us. And so I join with all of the panelists here to say this is what the COVID-19 vaccine means is freedom to return to humanity and to hug and hold and support each other and turn the page and continue the story of greatness for humanity. And that is a story for all of us, every one of us. So with that, I will turn it over to Dr. Amini Delman, who will try to wrap up with some key takeaways and any other closing comments she may have.
First of all, I want to thank you all deeply for your presentations, your openness, your honesty, your practical tips. This is really a wonderful panel, and it's been great to get to know each and every one of you and your personal stories. And what I said at the beginning, I truly want to echo now, which is you are champions, and thank you so much for all that you are doing and helping, putting your stories out there and your experiences out there so that others can follow in your footsteps. I'm a bit of an optimist, so this has been a really hard year for everyone. And I'm a big believer in big change comes out of adversity. And so the vaccine to me is going to do all the things that everyone here has said, but I also really hope that it changes our society. Not just public health, not just healthcare, but how we look at each other, how we treat each other, how we face adversity, and the resilience that we all need to have and need to teach our future generations. I think many of the children being out of school has been a real mental health crisis among adolescents. But what I hope comes out of that is what I've said, resiliency, and that there'll be a generation that will look to the world and ask themselves how they can make this better. So I hope that's really what comes out of not just the vaccine, but really ending this pandemic, that we leave our world better off after a year of, and hopefully just a year of what has been really, really a challenging situation. So thank you all deeply for everything. We are so sorry for those of you who have lost folks and are continuing to lose folks. And we know we need to go faster. And I know we're all working as hard as we can, as quickly as we can, across the country to make this happen. So thank you. Thank you so much. I think they were going to pull up our very last slide to sort of close out what we've learned, hopefully today. Great. So when we started, we talked about the purpose here being building bridges, and I think we've built bridges in many different ways, and really did a lot of thinking out of the box to not only think about how to build bridges between public health and healthcare systems, but much more broadly as we think about other groups within the communities and really a whole of community approach. But at the beginning, we set forth goals, and I hope at the end of this session, people do feel empowered and equipped to do the following things. One, to empower community members and vaccinated persons to promote vaccination in a whole of community approach. And I think you've seen ambassadors and champions here today that have taken this on and are role models for bringing this into the community. The second is to strengthen relationships, again, as we've talked about, not just among public health, and you heard from Dr. Kaufman, public safety and healthcare systems, but also more broadly, and really to accelerate equitable vaccine implementation throughout the country with the key goal of saving lives. That's what we're here to do. The third is to develop, and hopefully people feel equipped to develop innovative community vaccination strategies, including working with local healthcare providers, larger healthcare organizations, regional offices of CMS, state legislators, pastors, places of worship, obviously EMS, as we talked about, to really help ensure equitable uptake of vaccine in partnership with the trusted community leaders, and to really bring vaccines to people who may have never thought they were going to have access to it, like we've heard about. The fourth is to encourage folks to partner with local healthcare institutions, community organizations, building on some of those existing partnerships, but even creating new ones, and other trusted sources to really promote vaccine awareness and uptake within local communities, with particular dedicated, focused attention on institution and organizations that serve communities have borne the brunt of COVID-19 exposure, illness, and death. These are our Black and Brown communities, our socially disadvantaged communities. We really need to target our strategies to those most vulnerable. And lastly, to tailor strategies and approaches, hopefully based on some of what you've heard today, either the ideas or the concrete suggestions, across different diverse communities and settings to ensure really that the end goal is equitable access to vaccine for communities at higher risk. So, bottom line here, we want to make sure everyone in every community has access to vaccine and trusts that the COVID vaccine is the future of ending this pandemic. So I thank you all tremendously for everything you've offered. And all that you will, I'm sure, continue to do as we face the next several months. There is a discussion board to share information with each other, and we'd like to continue to share information. There are also there's a learning center where we've posted many of these resources, and just encourage continued dialogue. This forum is about bringing people together to share lessons learned, to share remaining challenges and barriers, and to really keep us moving forward. So this is not the end. In many ways, this is the beginning, and it's the beginning of us working towards really ending this pandemic. So thank you all so much. I don't know, Sue, if you have any last minute words.
Thank you all. This has been a real treat, and we'll see you.
And thanks for having your cameras in the background and all the pre-work. We really appreciate it.
Thank you, guys.
Thank you all.
Thank you.